All right, so welcome back. This is Medication Administration Part 2, and in this slide we're looking at oral medications. The advantages to oral medications is they're economical. They're typically cheaper than other types of drug therapy. It is usually safest and it's convenient. To provide oral medications to your patient, you will need a medicine cup, potentially a tablet crusher, a medicine dropper, drinking straws, a water cup, and a syringe, perhaps. Medication administration can be done in multi-dose solid format. So there's an example here essentially of providing pills. To do this, you remove the cap. You only touch the outside and not the inner side of the bottle. Remember, do not pour pills into the nurse's hand or patient's. Place it in the med cup. Stay with the patient until the medication is swallowed. And also give a sip prior to swallowing pills. Give narcotics that are irritating to the GI mucosa with crackers or food. And once medication has been poured, there's no returning it back into the canister. Whenever providing medication, it's essential that you educate the patient and explain to them the medication and the purpose. You will do one medication at a time. However, do know that you can administer more than one pill at a time. With multi-dose liquid medication administration, shake if necessary, remove the cap, and place the face up on a flat surface so that the part that attaches back to the bottle is not touching the top of the counter or wherever you are pouring this medication. Cover the label with the palm of your hand to prevent dripping onto the label that would then, in the future, prevent nurses from reading the label. Pour at eye level and measure at the lowest point of the meniscus, which is the lower curve of the liquid. Do not touch the bottle to the cup. And do cleanse the bottle before you recap if you have drips. If you overpoured, then you are to discard the extra. Do not return it back to the bottle. And page 533 in your skills book reviews the procedure that we just discussed. The picture here shows you unit dosed medication. You open it at the patient's side. That way, if it's refused, the medication is not wasted. You do not touch the medication. You put it in the medicine cup. And if necessary to bisect a tablet, do so before entering the patient's room. Before crushing a medication, you need to ensure that it can be safely crushed. Time-released medications, buccal, sublingual, enteric-coated tablets cannot be crushed. A tablet crusher or mortar and pestle work best. It can be okay to mix medication in food. And it is important to ensure that all medication is taken before you walk away from the patient. Your skills book talks about this on page 594. When providing oral medication, observe for reactions. Always check the medicine label. Provide those 3 checks and the 6 rights. And of course, you're always going to wash your hands. If you have a patient who has a nasogastric tube, to give them medication via the NG tube, you would put them in a sitting position. You check for correct placement of the tube. You'll check placement with pH, and you know that it should be 4 or less. You'll check residual. You'll check the markings on the tube and also the nose. You're going to prepare the meds. You'll have to crush them, and then you will follow the protocol in the book, your skills book, which is page 537. So you will dilute it with 30 milliliters of warm water, and then you'll drop 30 cc's of water to flush the tube. And you flush before and after giving the medication through the tube. Before leaving the patient, you want to ensure that the tube, the NG tube, is patent, and you also are going to follow up in 30 minutes to reevaluate the patient after providing the medication. When giving NG tube installations, you do count this as a part of your intake and output, and it's important to check the residuals. You instill the residuals back into the patient unless the volume is over 150 to 200 milliliters. And if that's the case, then you need to contact the doctor. You do flush with warm water before and after and between meds. Medications must be crushed separately and given separately through the feeding tube. On this slide, we're looking at ophthalmic medication administration. Remember that ophthalmic medications are meant to have a local effect, but if not administered properly, they can be absorbed systemically. Also, you do not put drops onto the cornea because this is a very sensitive spot, or can be a sensitive spot due to increased nerves. And we're going to look at this in the next slide. So we're going to look at that, eye installations. You're going to wash your hands, have the patient look up to the ceiling, with your dominant hand resting on the forehead, hold the eyedropper 1 to 2 centimeters above the conjunctival sac, and give the drops. Hold pressure on the nasolacrimal duct 30 to 60 seconds, and this is to prevent overflow into the nasal pharyngeal passages and then having a systemic effect on the patient. Do not touch the eye with the dropper. Have the patient close their eye and roll eyeball to distribute the medication and blot excess from eyelids with the cotton ball. With eye ointments, the process is similar. You are going to place the medication along the conjunctival border, starting at the inner canthus and moving toward the outer canthus. Have the patient close their eye and roll the eyeball to distribute the medication, and again, you're going to blot the excess away. Have the patient, or instruct the patient to not rub their eye and to remain supine for 5 minutes. When instilling eardrops administration, remember that with adults you're going to pull the ear back and up, and with the child you'll pull the ear back and down if they are under 3 years of age. Contraindications to otic medication would be a perforated eardrum, hypersensitivity, herpes or other viral infection, or systemic fungal infections. And your skills book on page 551 goes over the process. When providing medication into the ear, have the patient lay on their side with the ear up, instill the prescribed drops, and if ordered, you can place a cotton ball in the outer ear canal, but remember never to push things into the ear canal. With nasal medication administration, usually the patient is upright with their head forward. to administer the medication. The book on page 554 does identify alternative positions related to if it's supposed to go into the ethmoid, the maxillary sphenoid sinuses. Remember with nasal medication that long-term use of nasal decongestants can cause a rebound effect due to a diminished response to the medication. You do not want to use it longer than 5 days. And instruct the patient to clear the nasal passages prior to use. Suppositories can have many different intended effects, such as laxatives and anti-inflammatory, anesthetic, antipyretic, analgesic, or antiemetic. You will put the patient into SIMS on their left side with their leg flexed. Cover the patient except for the rectal area. Remove the suppository, lubricate your finger of your dominant hand, and apply. Spread the patient's buttocks and insert the suppository. On page 568, it also goes into this in your skills book. With transdermal medications, it is considered a narcotic, and most facilities have a proper disposal method, especially if it is for being provided for pain relief. Patches do consist of 4 layers, and always wear gloves when applying transdermal medications. And it's important to remove previous patches before placing a new one on the patient's skin. Inhaled medications are meant for local lung effect. However, it can also have a systemic effect due to rapid pulmonary circulation. An example is albuterol can increase the heart rate and cause tremors and palpitations. With a metered dose inhaler, you need to coordinate the spray with the breathing cycle to ensure full dose of medication has been inhaled. So to do this, you need to depress the inhaler as the patient inhales. Spacers can help with this. And also with inhalers, it's important to perform good oral hygiene. Oxygen does need to be prescribed by a physician, and dosage based on individual's need. It's ordered as liters per minute or percentage. And remember that with COPD patients, you need to administer oxygen at the lowest possible levels, because flow rates greater than 2 liters per minute can result in apnea for patients with altered respiratory drives. When providing oxygen, nasal cannula orders are usually 1 to 6 liters a minute. The higher the rate, it dries out the mucosa more. Anything over 4 liters per minute, you would anticipate humidifying the oxygen. A simple mask is used for short term. It fits loosely over the face, and it provides about 30 to 60% of O2. Non-rebreather mask does not allow exhaled air to be rebreathed due to the valves on the sides of the mask. Partial rebreathers, most exhaled air escapes, but some does remain. And then with Venturi, it reduces carbon buildup, and it does also can deliver high levels of oxygen. With the Venturi in particular, it's a very precise way to provide oxygen therapy. No smoking for patients who are on oxygen because it supports combustion. Avoid use of small electrical appliances by this oxygen, and always explain precautions to patients and family. Use gloves for ointments, lotions, and creams. Follow the directions. Remember, it's still a medication. Page 541 of your skills book goes over this. When you put on locally applied drugs, you do want to put on the palm of your hand that has gloves on, and then apply in the direction of hair growth. if hair is at the site that you are administering it. So that concludes this presentation. Thank you.